Question 1. A 62-year-old man presents with fatigue, night sweats, and early satiety. His spleen tip is palpable 8 centimeters below the costal margin. CBC shows WBC 180,000 with marked left shift and basophilia. Bone marrow biopsy shows hypercellularity. Cytogenetic testing confirms a reciprocal translocation between chromosome 9 and chromosome 22. Which of the following is the best initial therapy? The preferred treatment option is B, imatinib. This patient has chronic myelogenous leukemia, as indicated by massive leukocytosis, basophilia, splenomegaly, and the presence of the Philadelphia chromosome, a reciprocal translocation between chromosome 9 and chromosome 22. The best initial therapy is imatinib, a BCR-ABL tyrosine kinase inhibitor, which directly targets the underlying molecular abnormality and effectively controls disease progression. In contrast, hydroxyurea can temporarily reduce a high white blood cell count, but does not address the BCR-ABL mutation, and is only used for rapid cytoreduction. Ruxolitinib is indicated for myelofibrosis, not chronic myelogenous leukemia, and prednisone is used primarily for lymphoid malignancies like acute lymphoblastic leukemia, or for autoimmune conditions, not for chronic myelogenous leukemia. Therefore, these alternatives are not appropriate first-line treatments. Question 2. A 29-year-old Gravida 2, para 1 at 32 weeks gestation, comes with sudden abdominal pain and heavy vaginal bleeding. She has a history of cocaine use. Fetal heart tracing shows late decelerations and decreased variability. The uterus is firm and tender to palpation. What is the most likely diagnosis? The most appropriate answer is D, placental abruption. This patient presents with sudden onset abdominal pain, heavy vaginal bleeding, a firm and tender uterus, and signs of fetal distress. Her history of cocaine use is an important risk factor. These features are classic for placental abruption, where the placenta prematurely separates from the uterine wall, leading to maternal and fetal complications. In contrast, placenta previa usually causes painless bleeding without uterine tenderness. Vasa previa typically presents with bleeding at the time of membrane rupture, accompanied by fetal bradycardia, not a firm uterus. Uterine rupture most often occurs during labor in women with a prior cesarean delivery and presents with loss of fetal station, severe pain, and maternal shock, rather than occurring spontaneously at 32 weeks. Therefore, these alternatives are less likely. Question 3. A 61-year-old man with a 40-pack-year smoking history presents with sudden onset severe shortness of breath and right-sided chest pain. He is tachycardic and tachypneic. Trachea is deviated to the right, breath sounds are absent on the right, and percussion reveals dullness on the right. He is hypotensive. ECG shows electrical alternans. Chest X-ray shows a large right pleural fluid collection with mediastinal shift to the right. Which of the following is the most likely diagnosis? The patient's symptoms best fit choice C, tension hemothorax. This patient presents with sudden shortness of breath, hypotension, absent breath sounds, dullness to percussion, and right-sided mediastinal shift. Chest X-ray confirms a large pleural fluid collection with mediastinal displacement. Together, these findings are classic for a tension hemothorax, in which blood accumulates under pressure in the pleural space, compressing the lung and shifting the mediastinum. In contrast, a tension pneumothorax typically produces hyperresonance rather than dullness, shows air instead of fluid on imaging, and causes tracheal deviation away from the affected side rather than toward it. Massive pleural effusion can cause dyspnea and dullness, but usually develops gradually and rarely leads to hypotension, shock, or sudden chest pain. Cardiac tamponade may explain electrical alternans, but Beck's triad, hypotension, jugular venous distension, and muffled heart sounds, is classic, and chest X-ray shows an enlarged cardiac silhouette rather than a unilateral pleural fluid collection. Therefore, these alternative diagnoses are less likely. Question 4. A 9-year-old boy presents with multiple umbilicated skin-colored papules on the trunk and axilla. He also has eczema around the lesions. The mother says he frequently swims at a public pool. Which is the causative organism? The right choice is A. Poxvirus. This child has molluscum contagiosum, which presents as umbilicated, skin-colored papules and is often seen in children with eczema. The condition is caused by a poxvirus and spreads through direct contact or contaminated water, such as in public pools. In contrast, human papillomavirus causes warts that are usually hyperkeratotic rather than umbilicated. Coxsackie virus leads to hand, foot, and mouth disease, presenting with vesicular lesions on the palms, soles, and oral mucosa rather than umbilicated papules. Herpes simplex virus produces painful vesicles on an erythematous base, not the painless, umbilicated lesions seen here. Therefore, these alternatives are unlikely. Question 5. A 25-year-old man presents with chronic diarrhea, weight loss, and abdominal pain. He has had 3 episodes of kidney stones. Laboratory results show elevated CRP. Colonoscopy reveals patchy erythematous lesions in the colon with sparing of the rectum. Terminal ileum appears ulcerated and cobblestoned. Which of the following extraintestinal manifestations is most strongly associated with this condition? The best answer is B, erythema nodosum. This patient has features classic for Crohn's disease: chronic diarrhea, weight loss, hyperoxaluria leading to kidney stones, patchy areas of inflammation with rectal sparing, and cobblestoning of the terminal ileum. Among the extraintestinal manifestations, erythema nodosum is one of the conditions most strongly linked to Crohn's disease. In contrast, primary sclerosing cholangitis is strongly associated with ulcerative colitis rather than Crohn's disease. Pyoderma gangrenosum can occur in inflammatory bowel disease, but is more commonly linked to ulcerative colitis. Primary biliary cholangitis is an autoimmune liver disorder seen mainly in middle-aged women and has no association with Crohn or ulcerative colitis. Therefore, these alternatives are unlikely.